All right, welcome back to another episode of our podcast. I'm David Levine, founder and CEO of ResTech Solutions. And today with us, I have Dr. Demetrio uh,
Aguila.
Aguila. Thank you. So I will turn the floor over to you and let you introduce yourself.
Well, thank you. First of all, thank you for having me on as a guest. I'm really looking forward to our conversation. My name is Demetrio Aguila. I'm a peripheral nerve surgeon in the Omaha, Nebraska area. I run a direct care practice here in Omaha, and I'm also the leader of the Nebraska chapter of the Free Market Medical.
Today, we are talking about the hidden cost of outdated systems in healthcare and the tech needed to solve it. So, looking at your background, I know you've seen firsthand how outdated systems can slow down care and frustrate both the patients and providers. What do you think is the biggest hidden cost, financial or otherwise, of relying on legacy technology in healthcare today?
Well, I think the biggest hidden costs relate to the time spent dealing with the shortcomings associated with these different legacy technologies. So, as we think about, and as physicians in particular, I think about data entry. What we found over the years is that there's been this technological creep in medicine in which physicians have become more and more data entry specialists, as have their patients. I remember, my father is a retired physician, and I started working in his back office when I was 10 years old, and I was scrubbing toilets and emptying trash. And I remember watching my dad do his notes, and then he would dictate, drive that. For a 1 hour visit, maybe a total of 50, 5 to 15 minutes would be spent on it. Take a look at the average physician these days, about 60 to 65% of the time allocated for a visit is spent on documentation. And a lot of people will argue, well, that's because medicine has gotten so much more complex. I don't think that's actually the case because we see a lot of practices, like mine in particular, where we've decided to take a different direction. And we find that the time spent on documentation is back to being a small fraction of that time. What we find is that, a lot of the documentation requires us to jump through a bunch of insurance hoops trying to figure out, okay, what's the appropriate code, what's the appropriate evaluation management code, what's the appropriate ICD-10 code, the diagnosis code. All this coding requires us to check a bunch of different boxes in order to meet certain criteria so that we can satisfy the insurance companies. As a result, an entire industry has sprouted around this whole concept of coding. And we have administrators galore making sure that the coding is done correctly so that we can bill appropriately and so that we can make sure we're getting paid appropriately according to the rules that are set forth by the insurance company. Now, part of the challenge is that the insurance companies themselves, they have the playbook, they have the rule book, but they don't tell us what the rules are until after we've broken them and they say, well, you messed this up and so we're not going to pay you. And so there's a lot of time spent, a lot of cost involved, the personnel costs. There's time spent on the personnel, on paying those personnel, on getting those personnel to do those kinds of tasks. It affects the patients directly because it takes away from time that could be spent with the patient. It also affects the patients directly because when the patient shows up there to fill out all this paperwork, in order to make sure that we have all the right data entry points in order to satisfy the insurance company. The insurance company isn't the party that's receiving care. The insurance company isn't the party that's delivering care. The insurance company, however, sets up all the ground rules as an intermediary between me, the surgeon, and the patient, and that costs time and it costs money, it costs effort, and it causes a lot of frustration.
All right. And earlier you mentioned that your practice takes a different approach. Do you mind elaborating a little more on that?
Sure. So, as the chapter leader for the Nebraska chapter of the Free Market Medical Association, in our practice, we espouse a direct care model. That's a model in which we cut out the insurance company altogether. We significantly decrease our overhead in doing so, and we're able to deliver better care for patients that's more affordable. The average patient visit in my office for a new patient is anywhere from an hour and a half to 2 hours, and follow-up visits are anywhere from half an hour to 45 minutes. We don't rush patients through. They have an opportunity to spend more time asking questions, getting answers, making sure that they know exactly what they're getting. And very often we're able to deliver that care more affordably because we've cut out a lot of the administrative costs associated with dealing with the legacy system, and we've simplified the processes. And then with the help of certain technological tools that we're using, we've made communication simpler, easier, and more accessible for the patients. In many cases, we can save patients as much as 75% off of what they would otherwise pay, and they get better outcomes and greater satisfaction.
Well, thank you. And that actually, it's kind of along the lines of the first business related question I want to ask. Yeah, since you do have such a strong focus on that direct care model, you may have mentioned a little bit, but what was kind of the inspiration or what got you to this road to kind of blend your innovative surgical care with the focus on that transparency and direct care model?
Sure. Well, the transparency and fairness, it all boils down to the relationship between the doctor and the patient. In a conventional practice where they deal with insurance companies, the insurance company is really the customer. And, just like with any model, whoever it is that pays the bill gets to decide what that bill is paying for and what you get out of that. When I was a teenager, my dad said, "Okay, I'm going to help you get your first car." I wasn't the one that got to choose what color it was. I didn't get to choose what model it was. I didn't get to choose a car that didn't have a whole bunch of dents in it and a mirror that was hanging off, because I wasn't the one that paid for it. My dad paid for it, and so he was the one that got to make the decisions. When patients turn over these decisions to insurance companies, the insurance companies get to make the decisions. And so that was a source of frustration for me because patients would come in to see me and they say, "Doc, why did this cost so much? If I'd known it was going to cost that much, I wouldn't have done that." Well, I wasn't the one that got to decide how much anything was going to cost. And yet I was the one that was taking the blame for it. But what really pushed me over the edge was when I went to my first Free Market Medical Association conference in 2017. And that's when I found out the kind of impact that these insurance models have on patients. And it was Jay Kempton, who was one of the founders of the Free Market Medical Association. He was giving a talk, showing a case presentation for a typical scenario in which somebody who has employer sponsored healthcare, health benefits, the employer was paying for patient's total hip replacement. And he was comparing the cost at an insurance based facility, in this case, the University of Oklahoma, and then also at the Surgery Center of Oklahoma, which bypassed the insurance company would set up a direct contract with the employer. And I was shocked to discover that at the University of Oklahoma at the time, that total cost of care for that total hip replacement was 275,000. That's what the that's what the employer had to pay, of which 15,000 was the responsibility of the patient. And mind you, that was the money that was being paid to the insurance company, and then the insurance company would then go and pay the hospital, physical therapists, and all those parties. Compare that to the Surgery Center of Oklahoma, where you get better outcomes because a number of studies have demonstrated that the same surgery performed at an outpatient surgery center gets better outcomes than the same surgery performed at a hospital at lower costs. Well, if you use that direct contract and bypass the insurance company altogether, that total cost of care, instead of being $275,000, it's $15,000. So then you have to ask, well, where's that other $260,000 going? It's going straight into the pocket of the insurance company. Oh, and by the way, at the Surgery Center of Oklahoma, the doctors were getting paid more. The facility was getting paid more. The nurses are getting paid more. The physical therapists are getting paid more. The patient pays less. The employer pays less. You get a better outcome. Everybody wins except the insurance company. When I saw that and I realized, oh my goodness, that's $260,000 that the employer has to cough up. Well, whose pocket does that come out of? It comes out of the employee's pocket, either directly or indirectly, because every penny that the employer has to pay to the insurance company is a penny that that employer can't pay to the employee in compensation. And I started to hear stories of patients saying, I'm so glad you were able to help me with my health problem. I just wish I didn't have to be bankrupt in order. And when you consider that roughly two-thirds of individual bankruptcies in the United States are due to medical debt. I mean, that's a pretty scary number. And so everybody thinks, oh, well, we just need more insurance. Well, three-fourths of those people who went bankrupt due to medical debt already had insurance. Insurance isn't the answer in most of those cases. All it does is it drives up cost and doesn't really help patients with their medical concerns in the way that they think it does.
Um, it's some amazing stories. I've heard some similar, but that's very eye opening.
It certainly was for me. I mean, when I was sitting there in that conference, and I heard those numbers, I mean, my first thought was, how many of my patients had I done that to? Well, how about all of them, right? Because I didn't know any better, and I literally had to force myself to stay in my chair and not run out of that ballroom and just vomit all over the floor. I had such a visceral.
And so you had also alluded to some of the technology that you use in your practice just a bit ago. So how do you balance that using that cutting edge technology with keeping the care affordable? And I know you've mentioned about the direct primary model, but obviously there's a cost to having technology, and I know sometimes medical tech can be pretty expensive. How do you
Sure.
find that kind of harmony?
So in our case, we've partnered with a few different startup companies who are very interested in tailoring solutions to our practice, which is very different than the legacy technology that you were talking about earlier, where, you know, here's the way it is. You can have this car in whatever color you want as long as it's black, right? That's kind of the approach. Okay, here's what we have. You adapt your practice to the technology that we have. Instead of the way that it should be, where we say, no, 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 we'll adapt our technology to your needs. I mean, it's kind of like, again, let's use the analogy of surgery. Let's say, again, somebody needs a total hip replacement. I don't do total hips, but let's say somebody came to me and said, I need a total hip. And let's say I knew how to do that. I wouldn't say to them, well, you know what? The only implants we have are for people who are 6'9" and weigh 300 pounds. Well, you're 5'2" and you weigh 100 pounds. I guess we'll just have to adapt you to this implant. I mean, no surgeon would agree to do that. And yet, that's what we do every day when it comes to the technology in our offices and in our hospitals. And so these companies approached me and said, no, we're going to build the technology around you. We're not going to charge you anything until you're satisfied with the product that you're getting. And what we found was that, for instance, I started working with a company by the name of Confido Health, and they built a text messaging system around my practice, around our workflow, which allows us to send post-operative instructions to patients. Now, it took about 9 months for us to fine-tune it so that it was working exactly the way we wanted it to. But on average, a patient who comes in and undergoes surgery will receive 52 text messages over the course of 2 months following surgery, which are tailored to that individual, tailored to their specific post-operative needs, and they're timed in such a way that the time that we figured out that the patient was most likely to ask a question, we would send the answer before they even had a chance to ask the question. Embedded in those text messages are also links to videos so that the patients can hear me specifically telling them, look, here's what I want you to know. Patients told us time and time again that, they would leave the surgery center or they'd leave the hospital with a stack of papers like that. And they were confused. They're like, I don't know what I'm supposed to listen to. I don't know what I'm supposed to read. He said, let's just make it simple. We'll just send you text messages. All you got to do is look at the text messages. And if you didn't understand what you read, well then watch the video and you can hear me tell you face to face as many times as you need to hear it. So you don't need to worry about memorizing it in one hearing, which is what I think patients often feel like they have to do when they get the instructions from the nurse in the recovery room. We've heard from patients time and again that that's been transformative for them and that the communication that they receive has been absolutely outstanding. In the first month when we launched the prototype, we decreased the number of outgoing calls from our office by 60%. And in that same month, incoming phone calls, primarily those related to postoperative care, dropped by almost 70%. Well, that meant that the people who used to be spending all that time on the phone were able to allocate their time and their energy to other things which were more important. And we found that the utilization of our team was far more effective. It was more cost effective and it was much more satisfying for patients, much more satisfying for all of us because we're actually doing something far, far more important and something that actually requires a human touch.
That's phenomenal. I love to hear when businesses or medical practices are really using technology in such a way to basically free up the human capital for where it's needed most. And kind of along the lines talking about this. So as you've been building your practice at Total Pain Solutions, I know you've been talking about technology and process. We just talked quite a bit about the messaging. Which technology or process change would you say has had the biggest impact on patient outcomes or operational efficiency? Would it be this texting platform or something else?
So far, the texting platform is the one that's had the most tangible impact on our practice. That combined with the fact that we switched to an electronic medical record system, which is far simpler than what we used to use. We used to use an electronic medical record system, which did all this coding and did all this billing and did all these other things. 95% of what we were paying for, we'd never ever used. And we said, you know what? One of the advantages of being in a direct care practice is that we don't need to jump through all of those hoops. And so we were able to find an electronic medical record system, which was far simpler, really designed specifically for direct care practices. And we were able to cut our cost associated with the direct cost of the electronic medical record system from $1,800 a month down to $300. And of course, we pass that savings right on to the patient. But more importantly than that, because we're using a simplified system, the amount of time that we spend in that system is also reduced, which means the patient gets more of that time. It means that we're able to allocate our time and our resources to tasks that actually matter as opposed to the ones that are just a bunch of busy work.
Awesome. So I want to move on to a little more about you. So I know you wear a lot of hats. You know, you're a surgeon, entrepreneur, advocate, and even an educator with all the info you give to your patients. But what part of your role would you say brings you the most fulfillment day to day?
That's a great question. And I would say that the part of my work that gives me the greatest satisfaction and gives me the greatest fulfillment is the opportunity to give patients who have come to us hopeless the chance to rediscover and recapture the hope which they've lost. I'm a peripheral nerve surgeon. Most people have never heard of peripheral nerve surgery. So basically, I work on any nerve, just about any nerve that's outside of the brain or the spinal cord. And that's a subspecialty of plastic and reconstructive surgery, mainly because of our training in microsurgery. So I did subspecialty fellowship training in peripheral nerve surgery. And then from there, I further subspecialized in surgery on those nerves, specifically as it relates to pain. The subset of the population that I take care of comes to us with chronic pain that's been treated every which way you can think of. They've had injections, they've had stimulators, they've had radio frequency ablation, they've had all kinds of things, countless medicines, and they feel like they're at the end of their rope, and they've lost hope. And so they come finding us largely through YouTube. You asked earlier about what technologies have made a big difference in our practice. About 56% of our patients find us through YouTube, and about another 30% find us through Facebook. So social media has had a huge impact on our practice in reaching the people that we want to reach. And so these patients, they hear the stories of previous patients whom we've treated, and they say, "That's my story. I want him to do for me what he did for that person." And so these patients come and see us. About 50% of the patients that we see these days uh, come to us with post-herpetic neuralgia, chronic pain after shingles. We've seen patients from literally all over the world. We're up to 50 states and 32 foreign countries now. And that's because patients are looking for solutions that they can't find anywhere else. And so we offer them surgical, permanent solutions for their pain. These patients that come in with post-herpetic neuralgia, with chronic pain after shingles, I mean, their stories are heartbreaking. I've started to learn in the last few years that on the different online forums, these patients refer to this as the suicide disease because so many patients choose suicide over dealing with this pain for which they feel there isn't any hope. And when you consider that there's probably only half a dozen of us in the world that do surgery for this particular diagnosis, I can understand why those patients would feel hopeless. And so there's a great deal of satisfaction for me and for my team in knowing that we can help a lot of these people. They come in and we're the last stop on the train for them, and they leave here with hope. And after we've done the surgery, most often they leave here with their life back. And that for me is far more valuable than any dollar sign that
That's amazing.
it's quite a privilege to be able to take care of these patients. I mean, they put their trust in us. I remember my faculty advisor when I was in medical school used to say to us all the time, "Oh, your patients will get better despite what you do for them, not because of what you do for them." And I carried that with me. We have to find ways to allow their bodies to do what their bodies want to do. And we just kind of help that along the way. The same professor used to emphasize to us. He said, "You know what? There's a huge responsibility that goes along with wearing that white coat." You know, patients will place a great deal of trust in you and will share things with you that nobody else will ever hear or know because you wear the white coat, because you have the credentials, because you have those two letters at the end of your name, because I'm an MD. Patients will trust me. And it is my responsibility to make sure that that trust is well placed. And the satisfaction that I get from knowing that their trust was earned, it's indescribable.
Well, appreciate you sharing that. So I wanted to also ask, because I know we've talked about a lot. I know there's some pretty amazing things and exciting things that y'all do in your practice. But are there currently any current initiatives or new directions that you're looking at within the practice right now that has you pretty excited?
Yes, as a matter of fact, we're working on a research project right now to publish our data regarding surgical outcomes in post-herpetic neuralgia. Currently, in the medical literature, there's, I think, 7 total cases of surgical treatment for post-herpetic neuralgia that have been published worldwide. Our plan is to publish our data, and it'll be in excess of 200 cases. I think that's what we're looking at. So it'll have a huge impact on the way in which people will approach the treatment of post-herpetic neuralgia. Patients ask me all the time, how are you helping to get this word out there? Why isn't it there aren't more doctors that know about this? Well, because there hasn't been a whole lot published about it. And we're aiming to change that. And we're hopeful that these initiatives will help get this information into the hands of more patients and more importantly, into the hands of more doctors so the doctors can recognize, oh, there are options to treat this. I can refer this patient to somebody, or better yet, I can learn how to treat this myself. And then instead of there being 6 of us, maybe 10 years down the road, there'll be 6,000 of us. Like,
And for those who might be interested in that information, do you have kind of a timeline of when that might be available for those who are looking for it?
sure. So we're looking to publish a series of articles in the medical literature over the next 12 to 24 months. We're hopeful that the first article will be available within the next 12 months, and then you'll see a series of them being published in succession after that. One of the other initiatives that we're looking at is taking a lot of the data from these studies and then publishing snippets of that data in a way that's accessible for the average patient on the website so that they can look and see the data for themselves and see, okay, you know, what do these outcomes look like? What percentage of patients get better? What percentage of patients have this diagnosis versus that diagnosis? And the standard questions that people are asking, we're doing a lot of data crunching and data mining in our practice with the permission of our patients in order to help more people out there.
That's phenomenal. And I just, as we kind of get towards the end here and wrap up, I have one final question I want to ask you. So we've talked a lot about technology and the data and everything that you have going on. And with technology playing such a central role in patient care today, how do you ensure your systems remain secure and compliant, especially as more patient data moves into digital platforms?
Sure. So there's a number of different ways in which we do that. Obviously, we make sure that the platforms that we use are already HIPAA compliant. We also make sure that we have redundancy in our system. So data is stored both remotely and locally in order to make sure that if there's a problem with one, then we have a backup on the other side. We go out of our way also to not just respect the patient's privacy, but really take the extra step and protect their privacy. We anonymize a lot of our data. Obviously, for the research study that we're doing, all of that is anonymized so that even if somebody were to get access to it and they wouldn't know which patient was which. And so those are a number of different mechanisms that we use in order to protect the data.
Thank you. I mean, are there any final thoughts you'd like to share or wrap up with?
I'm just very grateful that you've asked us to be a part of this. I'm hopeful that through this we'll be able to reach more patients, we'll be able to reach more doctors, and help restore hope for those people that have lost it.
I hope we can help you do that as well. I do appreciate you. This is honestly very fascinating, the story and just the work that you're doing. Very eye opening.
Thank you, thank you. It's been a privilege being on your show.
Appreciate you coming.